Well, hello, everyone. I'm Dr. Joe Gogler. I'm professor and Robert L. Kane Endowed Chair in Long-Term Care and Aging in the School of Public Health at the University of Minnesota. I also direct our Center for Healthy Aging and Innovation, and I heartily welcome you to the first session of Mini Medical School Aging and Health. We are excited to have you here today, and we look forward to guiding you through our first topic in the series, A Local to Global Look at Aging. We're going to begin with a moderated discussion followed by a question and answer session. You can submit your questions to our panelists at any time using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. And please note that this session is being recorded and will be available starting tomorrow on the Office of Academic Clinical Affairs YouTube channel. We'll also share the link to the recording with you by email. So again, really welcome you here. Before we get started here, wanted to really briefly tell you a little bit about the Center for Healthy Aging and Innovation in a couple minutes and invite you to engage with our center. I don't know if I can share my screen, however. So I think we're just going to move ahead with the, can I share? Oh, wonderful. Thank you so much. So again, I just wanted to share with you the vision of the Center for Healthy Aging and Innovation, which we really believe is a university-wide, but also a community-wide and Minnesota-wide center to advance really healthy aging. You can see our vision there. Our center is quite large now. It includes 157 members across 64 units, departments, and centers, not only at the University of Minnesota and beyond. So if we have faculty, staff, and students interested in participating in our center, please let us know. We have 98 community partners from 64 external organizations. Again, one of our core principles is a center that's outward facing and engaged with our community, not just in Minnesota, Minneapolis, St. Paul, but beyond as well. So if you're interested in being part of CHI as a community partner, we heartily encourage you to contact us. And again, as I had mentioned, that includes a very robust student organization as well, the Aging Studies Interdisciplinary Group. Now, like you to connect with us. If you have a chance, please do tweet us at UMN-CHI. You can see our website there. Our email is very easy to remember. It's CHI, C-H-A-I, at umn.edu. So again, we would very much be excited to engage with you and encourage you to get involved in the many great activities that our center is currently engaged in. And one thing that makes this event particularly exciting for me to moderate is the fact that so many of the panelists are actual members that actively contribute to the Center for Healthy Aging and Innovation. And what I'd like to do is to introduce our panelists. And I really have such privilege in speaking with all of them and sharing with you what the current landscape of aging looks like both locally and globally. So first, I'm going to start with a very close colleague of mine, Dr. Rajan Moon. Dr. Moon is the faculty director for long-term care administration in our College of Continuing and Professional Studies. He also is appointed to the Governor's Council on an Age-Friendly Minnesota. Most importantly, I want to point out that Dr. Moon is also an Associate Director of Education, the Associate Director of Education for CHI. His experience includes working at the Minnesota State Unit on Aging and leading the Minnesota Leadership Council on Aging. So let's kick it off with the first question to Dr. Moon. Dr. Moon, can you discuss what aging looks like in Minnesota and share more on aging for LGBTQ communities?
Absolutely. Thanks so much, Joe. And welcome everyone to this evening's session. Very excited to be here with you and my colleagues on the panel. And I'm here when Joe approached me to talk a little bit about aging. I really wanted to talk about two different topics, some comments on each of them. And I've really tried to distill sort of major points that can be expanded on during our Q&A session. So the title of my comments really is Developing a Multi-Sector Blueprint for an Age-Friendly Minnesota and Exploring LGBTQ Aging. So seemingly two different topics, but I'm going to try and weave them together. So, Minnesota is embracing an age-friendly ecosystem model as it works to develop a multi-sector blueprint for an age-friendly Minnesota. And this work really builds on decades of planning efforts related to the demographic shift occurring across the state and across the nation and for much of the globe. In fact, in 2020, older adults surpassed the number of school-age children in Minnesota, culminating just last year in 2022 when Minnesota counted 1 million older adults. This is the largest number really in our state's history. And like much of the nation, this demographic shift has created both opportunities and challenges for the state that will follow us into the foreseeable future. And really, when you're using an age-friendly approach, it focuses and leverages the opportunities and assets of the demographic shift. But it is important for us to recognize that challenges do exist. The challenges we're experiencing, for example, include a severe workforce shortage across the board. For example, in October 2022 alone in Minnesota, there were 11,000 admission denials to senior care due to workforce shortages. There have also been significant increases in healthcare and safety net expenditures. There's really an electorate that is unapologetically focused on education and youth, which I think we all can agree is an important group, an important population to focus on, but it comes at the detriment to other populations and can be riddled with systemic ageism. We also have migration of younger people from rural communities to metropolitan areas, which is really exacerbating some of the challenges for our rural communities. And while Minnesota is a great place to age, we're consistently ranked as top in our provision of long-term services and supports, as well as our caregiver support system. When you begin really to look closer at the data, you see significant disparities between BIPOC and LGBTQ communities and their peers. And in fact, these disparities are some of the highest in the country. So what is Minnesota doing? Well, in 2019, under an executive order, Governor Tim Walz formed a temporary governor's council for an age-friendly Minnesota to coordinate efforts across state agencies and private partners. And really, the main purpose of this council was to provide recommendations to the governor's office on moving age-friendly work forward in the state. The council is comprised of 9 state agencies and 6 public members. And in December of 2020, the council submitted 9 recommendations on moving forward. All these recommendations were framed within this equity lens to mitigate and eliminate disparities. In 2021, the council facilitated the enrollment of Minnesota as the 10th state in the nation in the World Health Organization AARP network of age-friendly states. And this year, the council received grant applications requests of almost $9 million for the $2.5 million we have available in funding. So there is clear demand in communities across the state. And a team in Minnesota is currently working with a collaborative of 10 states facilitated by the Center for Healthcare Strategies. And this learning collaborative is providing technical assistance across states to support successful state plans. The age-friendly frameworks, whether we're talking about communities, health systems, universities, public health, or others, offer methods for organizations, collaborations, and governments to assess their community, develop an action plan to promote change, and evaluate the outcomes of that plan. All of these various initiatives come under the umbrella of an age-friendly ecosystem. So simultaneously with the work on age-friendly communities, various stakeholders have been working on other age-friendly initiatives in Minnesota. The table that you see here on the slide depicts 4 of the most recognized frameworks, but there are others, including businesses, arts and culture, etc. The Minnesota North Star Geriatrics Workforce Enhancement Program has been implementing the Age-Friendly Health System Initiative in 2 federally qualified healthcare centers, and also translating that model to dental practices with the Minnesota Department of Health. The University of Minnesota was the first school in our state to join the global network of age-friendly universities, and we invite you to take part in Age-Friendly University Day on June 26th. Give us a Google and join us for a great day. And we were followed by St. Cloud State University. There are other initiatives. The Minneapolis Institute of Art is implementing an age-friendly museums framework. And there are parallel initiatives in various sectors around the topics of dementia friends. So in response to the demographic shift and reframing of aging, age-friendly initiatives will continue to diffuse across the nation. For healthcare providers, the adoption of the age-friendly health system framework is critical. And many of these initiatives begin as grassroots efforts and have since evolved into more formal models connected through an age-friendly ecosystem. So I'd like to flip gears just for a couple minutes. Dr. Gogler asked me to provide some information and comments on the intersections between the LGBTQ community and aging. Much of what we know about LGBTQ aging is thanks in large part to a few monumental studies. As data are not regularly collected on sexual and gender minority communities, we really have to rely on local and statewide data collection sources. Two such studies include our own Minnesota LGBTQ Aging Needs Assessment, which began in 2002 and was replicated in 2012 and 2022. In 2022, the 46-item online survey really helps tell the story of sexual and gender minority older adults, including glimpsing into their families, finances, housing, healthcare, and experiences with service providers and clinicians. The Goldson Institute is probably one of the first large studies on LGBTQ aging. They utilized BRFIS data to explore health status and outcomes. So from this research, it's well documented that LGBTQ older adults experience significant health, economic, and social disparities in comparison to their peers. They're more likely to be single, to live alone, to have chronic diseases like heart disease, some cancers, and dementia, to have depression and mental distress, and are less likely to have a friend or family member to help them. Here at the University of Minnesota, we're exploring the experiences of LGBTQ older adults in senior care and testing an education intervention to determine its effectiveness in changing knowledge, attitudes, and behaviors of direct care staff. So research suggests a complex paradox of LGBTQ aging. First, LGBTQ older adults are more likely to experience chronic illness and health conditions that require support. Second, LGBTQ older adults are less likely to have friends or family members to provide unpaid, informal support, thus more likely to require paid formal support. Yet at the same time, third, due in a large part to experiences with providers, including trauma and homophobia and transphobia, LGBTQ older adults are less likely to seek out formal support. So I'm going to end my comments by saying, what can we do as clinicians and providers? Well, there's a threefold intervention proposed. First is to create a welcoming environment. Our 2022 Minnesota LGBTQ Aging Needs Assessment asked older adults, what signals a welcoming provider to you? This question elicited over 300 qualitative responses, and they were coded into categories and themes. And we developed the top 10 ways to support an LGBTQ welcoming environment. And they include things like visual cues, hanging a rainbow flag or sticker, intake forms that use inclusive gender and pronoun options, provider reactions during intakes and assessments, and identification as being an affirming or welcoming provider. Second, provide person-centered and culturally responsive care. Quickly disappearing are the notions and older models of treating everyone the same or treat someone as I want to be treated. These are being replaced by more sophisticated frameworks through person-centered care, shifting to treat someone as they want to be treated, utilizing the age-friendly health system framework and the Pinnacle What Matters component can support person-centered and culturally responsive care. And lastly, know when to bring in others. In clinical and other settings, we're typically part of an interdisciplinary or interprofessional team consisting of physicians, nurses, social workers, spiritual care, et cetera. And each one of these members can bring unique perspectives and experiences to ensure an LGBTQ older adult feels welcome and receives the highest quality of care. So I hope these very brief comments, which both are a course that you can take at the university, so a very brief comments provided some introduction to age-friendly initiatives, as well as LGBTQ aging, and some of the challenges and opportunities with both. And I look forward to our conversation later. I'll turn it back to Dr. Gogler.
Thank you so much, Dr. Moon. We're so thrilled to have Dr. Moon and his robust expertise here with us at the university, as you can see, and excited to talk with him more about some of these critical and key issues in aging, both in our state, country, and world. And it's now my pleasure to bring in Dr. Joshua Fergan. Dr. Fergan is a senior research associate for the Memory Keepers Medical Discovery Team. He works on rural issues related to Alzheimer's disease and dementia care. So Dr. Fergan, can you discuss aging in rural Minnesota and implications for dementia care?
Absolutely. Thanks, Joe. I'm going to share my screen here and get started. All right. So today, as you heard, I'm Josh Fergan. I'm a senior research associate, and I'm at the Memory Keepers Medical Discovery Team. And that's part of the University of Med School's Duluth campus. And my background comes from rural sociology. So I take the rural title very seriously. And I want to start by looking at this map. You may disagree with it, but when I talk about rural Minnesota, I'm referring to all the green areas and occasionally the orange areas, because you could make a argument that these places have a rural nature, rural culture, or are places rural people tend to visit quite a bit. Everything red is what I'd consider metro, so this focus will be on everything that's not red on that map. There's that disclosure statement. As you've seen earlier, rural Minnesota is getting older. It's older than urban Minnesota. I can pull up graphs, demographic figures that kind of show this difference. But if we already kind of know that, what I'm more interested in is where these differences are becoming more extreme. And when you start looking at rural aging in Minnesota and looking at these projections to 2040, we see that we're going to get older, a larger cohort of 65 and older and 75 and older. But when you look at where these folks are going to be aging most rapidly, you kind of see some of these rural counties light up, particularly in the Northeast and a few counties kind of in the Southwest. And this is pretty problematic because these are pretty far rural and remote areas. And when you start breaking down beyond the county, what you actually see is outside these large counties like St. Louis counties, it's actually the communities the furthest away, the furthest north that are aging the quickest. They're the ones that have the higher percentage of 65 and older. And when you add the layout of hospitals, rural clinics, and interstate systems, you see that there are some significant access issues and challenges, particularly in the winter months, as we're all enduring now. Imagine trying to get from Grand Marais to Duluth in the wintertime. I mean, it's really, really challenging. And these also happen to be the places where there's just a higher proportion of those 65 and older. There are many reasons for this aging, right? One of the big ones that is frequently talked about from kind of the rural perspective is transformations in rural economies, which has happened for a long time. Significant transformations in the technology of agriculture from the 1920s have kind of saw this reduced need for human labor. And the same thing for mining. Technological advances can replace human labor with technology. And kind of the gist of the story is in a lot of these places that are based in agriculture or mining, they're the ones that tend to lose the most populations. Recreational counties kind of have varying effects. Some of those lake counties, counties where there's a lot of lakes and second homes, they see some modest growth. But overall, we see a general depopulating trends across rural Minnesota, particularly with mining and agriculture. And then when you look even further into some of these issues in rural areas, particularly around disparities, geographic disparities, you find that these factors that challenge healthy aging have unique spatial patterns that tend to be clustered in rural areas. This includes the percentage of 65 living alone, those who have broadband access, and then no health care coverage. Just for a quick reference, the red means high levels of that indicator and blue means low levels. So this middle map with broadband access is actually highlighting significant challenges for telehealth if they want to embrace this kind of this virtual type of care to overcome some of these geographic challenges. And then with healthcare, we see some of these other discrepancies that pop up along American Indian reservations as well, which happen to be also located in very rural areas. So what we do at CERTR is we're looking at understanding kind of these unique perspectives, barriers, and facilitators to rural dementia care. We are in the process of doing 100 interviews, and we're talking to rural physicians, caregivers, informal caregivers, nurses, health leaders, and eventually persons with dementias. And one of the main challenges they talk about is that rural to urban migration that was mentioned earlier. We know that there's youth out migration, but what this means, as it was alluded earlier, is there's a loss of support systems. And that's really critical in rural areas that tend to be under-resourced in terms of healthcare infrastructure. There's a more reliance on, and there's a higher significance of family filling in that void. They also have aging local healthcare systems. This next generation of people are leaving, or maybe they're getting trained as certified nurse assistants in their rural nursing home, but once they get older, they'll go move to a larger city and maybe make a little bit more money for that same job. There is urban to rural migration to a smaller degree, but I think that's more of the minority than the trend. And here's some of the quotes that really kind of capture that feeling, right? So many of the children, they're leaving. And so a lot of our families don't have close relatives to draw on for support. A lot of these people who are running things are starting to age out of these systems, and our kids just aren't staying anymore. So this leads to the next challenge. Well, if there's a lot of youth leaving, there's going to be a lack of staff to fill some of these healthcare needs. And this is really detrimental to rural communities and rural seniors. It hampers their ability to age in place, and it leads to an over-reliance on other services from nursing homes in order to stay in the community, because these are the only places you can get that 24/7 care. Some of these constraints that were mentioned in our interviews include lower pay in rural areas, the demographic shifting around COVID-19 and how that sent some people moving to different locations or into new living arrangements. A lot of people mentioned burnout, kind of constantly being in a state of triage, trying to take care of everything. And this leads to an over-reliance on volunteers, which is nothing new for rural communities, but it's getting harder to find those volunteers, particularly with COVID and vaccination requirements. This leads to a bevy of impacts, including longer wait lists, more travel for healthcare, limited home-based care services, because those services are there in theory, but if they're understaffed, you're going to have long wait lists and not be able to access them. Limited capacity for local healthcare, and there's been a gradual loss of rural clinics and hospitals. And this leads to this perception that once you get dementia, you're going to go end up in a nursing home, where you will encounter more wait lists. And this was a really powerful trajectory that a lot of our participants stated. It's this perception, once you get the diagnosis, you have to go into the nursing home. It's just this long-standing cultural thing, this path, this trajectory that we're all sort of on in some way. I'll let you read a couple of those. So despite all these challenges, right, how do rural communities cope? Well, we're finding some things that, some assets that rural communities have to kind of combat this lack of healthcare infrastructure. These limited staff and small social networks, they're used to making ends meet, and they find creative ways to stay engaged. And a lot of that comes from their commitment to each other and to their rural communities. Fortunately, a lot of people know each other. They know these families, these last names. And there is a sense that helps kind of bring this commitment out of these local healthcare infrastructures to really have all eyes on the community to help them out. And the fact that rural people have so many multiple hats and multiple roles, this actually allows for a lot of creative solutions to take place that are uniquely situated for a very specific rural community context. And there's just a couple quotes that kind of talk about, this strong network, finding creative answers, and something unique about rural communities that you might not find in larger urban areas. And then I'd be remiss if I didn't say there is a gradual culture change around aging and seeking services. There is an increasing presence of home-based care services, hampered a little bit by the lack of staff. But the important thing is the culture is changing. Rural seniors are becoming more proactive in their healthcare, and people are starting to see that asking for help or looking for these services is not a sign of weakness, but a sign of strength. And we're just starting to see this gradual mindset change that maybe I don't have to go to the nursing home now. And anytime we can keep rural seniors out of the nursing home, it's a good thing. And there's a quick little shout out to the CERTER team that helped me compile this data, and I'll kick it back to Joe.
Great. Thanks so much, Josh. Very, very intriguing, and excited to talk more about this topic too later in our webinar here today. And now we're going to turn to our third panelist, Dr. Tenzin Namdul. Dr. Namdul is an assistant professor and the director of the Tibetan Healing Initiative Program in the Early Bakan Center for Spirituality and Healing. He's a medical anthropologist and a Tibetan medicine doctor, driven to understand mind-body relationship in aging and memory through the lens of biocultural and Tibetan medical paradigms. Dr. Namdul, can you share Tibetan perspectives around death and dying and grieving?
Of course. Thank you, Dr. Gockler. Let me quickly share my screen. Sorry, it's taking a bit of seconds here for my screen to get adjusted here. Okay, great. Thank you again, Dr. Gockler, and good evening, everyone. So my remark today is based on two different studies conducted in the same population. The first study, which will be the major portion of my talk today, is 18 months of ethnographic study in Tibetan refugee community in southern India. So now we're going from Minnesota to all the way to southern part of India. In that study, I was looking at the conception of death and dying, and how they die and how they care for the dying. And the second study is a year-long epidemiological study where we were examining the prevalence of Alzheimer's and related dementias and its associated factors among Tibetan monks. So although I won't spend too much time on the second study, the epidemiological study, it's important, I think, to talk a bit about this study here because it shows a close association between how we age and how we die. And furthermore, I want to emphasize that even though the topic of my presentation today would be on death and dying, it is very much about living, particularly in the later stage of life course. So just to kind of give you a bit of a context by talking about the field site, which is in southern India, as I mentioned earlier, in a Tibetan refugee settlement called Monkot. Monkot, as you can see on the screen here, the map here of India, you can see a red dot down there. It's in the northern part of that state, in Karnataka state, between two major metropolitan cities, 400 miles south of Mumbai and 240 miles northwest of Bangalore. So it's kind of a sandwich between these two big cities. Monkot, the Tibetan settlement, is one of the largest Tibetan settlements outside of Tibet. The settlement is considered a mini Tibet within India for being the repository of traditional Tibetan life and culture. This settlement was first set up in 1966 on over 4,000 acres of land allocated by the government of Karnataka for thousands of Tibetan refugees who escaped to India from Tibet along with the Dalai Lama in 1961. So today it contains one of the largest concentrations of Tibetan refugees in India. So I want to share with you all, in this particular society, the way they have developed certain techniques in dealing with their own mortality, because I mean, when we talk about death, different cultural settings would deal with death or dying in a different way. But this particular society, the way they have developed a very specific or an idiosyncratic way of dealing with the death. What is fascinating is it very much has a certain level of social cultural utility as well as contemplative practices or cognitive practices associated with death and dying. So for instance, when they talk about death, they would constantly use death to animate some of the fundamental Buddhist concepts. Here I only have a concept of impermanence, which I would believe that most of you would know that, and especially in Indian classical or Tibetan Buddhist tradition, impermanence is a constant reference that's being used. So death the fact that we all have to die is used in a very effective manner when it comes to the cultural, social cultural way of referencing something related with impermanence. But once they are able to build up this relationship with death, the other way of looking at death is really how you can actually empathize, how we can develop profound compassion for others suffering. And so when one is going through a sudden level of degeneration of our body and mind, trying to shift that gaze from oneself to others and trying to see how other might be suffering, how other might be going through such kind of a same situation, and therefore generating or developing profound level compassion. And the final thing is really trying to use the sense of mortality or death to shift one's perspective to life and relationship, not only to oneself, but also to others, right? And so impermanent or the impermanent nature is used in a way to illustrate how you can actually create an antidote for certain things like attachment or desire or greed. If you look at the dying itself, and this is another interesting thing, which when I initially went to the field, because as most of us would know here, that when we do an ethnographic study, we would spend years of, this one is for 18 months. And so when I was there, dying actually for these community members, especially more among practitioners, is really more about trying to understand when you are actively dying, what different changes are happening, both at the physiological and the psychological level, right? But not only the physiological and psychological level, but also at the different state of consciousness. So from the gross, which they would refer to as our sensory consciousness, to the subtle and extremely subtle levels, which is like kind of a more metaphysical, kind of a meta-analysis level of understanding and using your consciousness. And what they do by understanding that level of different state of physical and psychological level is to engage in some very advanced meditation. For instance, they would, as you would see in that image, the meditator who are actually almost look like dozing off, he has been dead for almost 5 days, and he at that time was still in the state of meditation, and which they call a tukdam, right? So tukdam in Tibetan literally means being able to tame or control your subtle consciousness. And that's some kind of a unique, very unique cultural phenomenon that happens in this particular society. Now, why it is important to engage in certain meditative practices while dying, why it's critical. So I spent a lot of time talking to many different practitioners, and according to most of the practitioners that I spoke to, they would say that at the time of dying, when sensory consciousness fades away, which usually is one of the main sources of distraction, our capacity to concentrate on a specific object becomes very powerful. And they would say that being able to engage in contemplative practice at this state of extremely subtle consciousness is exponentially more effective than while we are in the state of gross consciousness, like when we are now, when we are alive, when we can respond to all the external stimuli that we are exposed to. And they would add that that's when these practitioners use the state of very subtle mind to engage or continue their meditative practice. And the question is really, it begs a question, what they will be doing when they are able to stay in that kind of a meditation is they would say that they would use that moment of consciousness or the state of consciousness to investigate the reality of our nature, the reality of interdependent nature, and by understanding or gaining in wisdom of the fact that we all are dependent upon each other, how you can cultivate a genuine sense of compassion toward oneself and others. Now, one overarching theme that comes up during the research is really about generating mental strength, or what they would say heart power. In Tibetan, they would use the term nyingtop. And it's really, again, it's all about protecting, safeguarding, using different state of consciousness. So the one thing is being able to stay extremely focused, but what should be the subject of that object of their focus? And they would say it's the virtuous mind. Once these two particular elements comes into being, that can translate into being able to generate mental strength. And that could happen in the face of any kind of adversity. And here in our context, it's at the time of dying. And this is a very kind of a little confusing, yet especially thinking through the model that they have developed themselves, and they don't necessarily kind of talk about it every now and then, but it seems like that's a kind of flow chart they could have in their mind. So we see this light blue circle right in the middle called emptiness, right? So emptiness is really when these practitioners would investigate if there's any intrinsic independent self without relying on anything in that individual's environment, you come to a conclusion that there isn't really much of a independent self there, and therefore the term emptiness. And they would use the concept of interdependent nature, right? If it's not for everyone sitting here and listening to us, it will be quite a futile attempt for us to say something. And so having that wisdom or understanding would really galvanize them to engage in loving kindness and compassionate act, which would directly link them to living a life of morality and integrity, and therefore feeling secure or confident, not only at the time of dying or in the face of adversity, but for these practitioners, when they engage in specific meditation at the time of dying, to be very confident about their next life. And so this particular cultural setting has a very strong belief that there's a continuation of life, and therefore having that kind of a secure confidence at the time of dying would help them to be at peace and be joyful at the time of dying. And so in terms of grieving, it's interesting because every time I would go around and attend to people caring for dying people or who have already died, the overarching goal is really to protect the person's mind or person's consciousness. Because in this particular culture, again, there's a strong belief that when someone is dying and someone is already dead, their subtle consciousness is still in the body. And so therefore the whole thing is really, the images that you can see here, the layperson who is reading the text is from the text of Tibetan Book of the Dead, where he was showing me, I was sitting right beside him, was showing me that it says in a very simple and understandable way of what different physiological and psychological changes would happen, and kind of a guiding the dying person or the deceased person. And you see on the other side of the image where both the lay and the monastic members will come and care for the dying person, and then the monks will collectively sit and again read either the Tibetan Book of the Dead text or any other related text. Now this brings me to my last slide. Is really kind of after I finished my doctoral research, I was really looking at how we can actually translate or have any implication on the brain health and therefore the aging. And so that brings in the epidemiological study I was alluding to earlier, where based on the preliminary results, we found that despite high prevalence of some metabolic disorders in the forms of health conditions, where we saw that there's a high rate of diabetes or blood pressure, hypertension, as well as behavior in terms of these monastic communities are getting far less sleep hours than we would usually prescribe, right? And they almost all of them experience quite traumatic event, especially being displaced, being forcefully migrated out of their homeland and having to acclimatize to very hostile climatic and environment conditions. But with that kind of a risk factors, we didn't find any cognitive impaired case, neither any Alzheimer's disease case. In fact, what we found was these monks seem to age extraordinarily well relative to other communities that we have seen in literature, existing literature. So our research team currently is working on designing a longitudinal study in this population focused on healthy aging. So I will end my remark here and look forward to our conversation. Thank you.
I just wanted to take the time to thank all of our panelists here today for their excellent presentations. I'd like for us to move on to the questions that have been submitted here. And again, as a reminder, please do submit your questions to our panelists using the Q&A box, which can be found by clicking on the Q&A button at the bottom of your Zoom screen. So I'm going to start with the first question I see in the Q&A. This is from Judith, and I think we'll direct this to you to start, Dr. Moon. Can you, and it's a big question, so I think all of us can probably tackle it to some extent, but can you please discuss gender differences in aging?
Sure.
That's its own,
how much time
that's
do we
its
have?
own presentation, I
Yes,
think.
right.
So, yeah.
Yes. So there are significant differences as it relates to aging when it comes to gender and gender identity. Take, for example, women. Women still live longer on average than men, have a higher life expectancy, though that number is sort of shrinking a little bit. Women are more likely to serve as caregivers. And by caregiver, I mean both informal unpaid caregivers, but also paid caregivers in nursing homes and assisted living facilities. The highest rates of poverty are for lesbian older women. Some of the highest rates of solo aging or aging alone are with gay men. So there's all kinds of different examples of disparities or differences between gender and gender identity. So maybe those are just a few that I would throw out there. I'm not sure if anyone else has thoughts as well on that.
What do the other panelists think? So and then I'll weigh in briefly myself.
I'll jump in. One thing we found out, to echo your point, is that with caregiving, the older men with caregiving for someone with dementia tend to burn out quicker than women. So what this means is women tend to get into nursing homes quicker if their caregiver isn't able to kind of adjust with those things. We also notice a few issues with stigma that kind of varies by gender. And then kind of the health-seeking behavior of rural men versus rural women. It's harder to get guys to go into the hospital, but we find that, there are some ways in which women and children can help convince that to occur, especially when rural male seniors start experiencing cognitive decline. They tend to be really resistant to screening and preventative health when it comes to memory.
Tenzin, were you going to add something?
Yeah, just a quick one. Thank you, Joe. So for the current study, the epidemiological study we are doing, it's only on monks. But my earlier study, it was really across the community in that particular geographical area. And one thing which is really interesting, which is quite also, I guess, similar here in the West, is the elder female or the woman tend to seek help so much more than the men. And so most of the people who were diagnosed with terminal illness or people who are actively dying, I was able to be there and by their side when it was commonly more a woman patient. It was really when I would be called over, and if someone is just almost dying or already have died, they were the male patient. So I think there's really a difference in terms of also seeking care, and also in a community setting where I did my research, they don't really have much access to healthcare or hospitals in general, but still they will find ways and means to reach out to other community members or traditional doctors to seek help. And so that's something I think which we need to consider when it comes to gender, I think.
Okay, wonderful. Let's move on, and I'm actually going to pivot a little bit, keeping in the gender theme to some extent. And Tenzin, I'm going to start with you here. So Linda asks, I'm intrigued by the monks aging well and relating that to studies of American Catholic nuns who also seem to age better than the general population. Your thoughts? So I think Linda's referring to the nun study. Exactly. And so Tenzin, I'd like to hear what you think and your reflections on that.
Absolutely. Yeah. Thank you for bringing that up. And I think the Snowden, if I remember the researcher name correctly, is from the University of Minnesota, right here. And yeah, every time we engage in a conversation about monk study, the nun study would always come up because it's a pretty significant and well-known study, especially in the West. Over there in the area where we are doing research, our goal is really down the road to also have, compared to the monastic nunneries, in terms of the infrastructure as well as the sample size is much smaller than the monastery. But what we have, based on a very little information that we have from that area, most of the nuns are much younger than monks, because many of them have come from Tibet. Most of the monks and nuns are the nuns who have either enrolled in the nunnery from the local area, or who have recently arrived from Tibet. And so I think I know very little about that, other than the nun study, which has
Yeah.
already been done there.
So let me ask you this, Tenzin, and I'll share my thoughts about the nun study here next. So Tom asked, what is your sample size in the monk study?
Right. Yeah. So for this current study, we collected data from 206 months. So it's more a kind of a preliminary or the pilot study to work on designing a larger study to apply for R01 study. And what we did to make sure that we make best use of our sample size, even though it's a decent size sample, is not only collecting survey and the biosample, but we also collected a qualitative data in terms of doing a clinical cognitive interviews and semi-structured interviews. So that's our sample size for now, but we're hoping that for the larger study, we would have 500 to 600 monks enrolled in the study.
Yeah, I think, the nun study is fascinating in and of itself. For those of you that aren't as familiar, it started back in the late 1980s when Dr. Snowden was here as a professor in the Division of Epidemiology. He later moved to the University of Kentucky. My first faculty position was there, so I got to know and talk with Dr. Snowden often. And, the nun study in a way has served as the template in many ways for subsequent studies that have sought to understand kind of the life course and trajectory of Alzheimer's disease, and to some extent trying to understand the insights as to what could lead to brain health after we pass away. And there were, for those that don't know, the nun study was really done in collaboration with the Catholic School Sisters of Notre Dame. I think Dr. Snowden included around 4 or 5 convents sites around the U.S., one of them being the convent site in Mankato, near Mankato. And I would argue there are 2 main findings from the nun study. Again, these are nuns. They donated their bodies to the study of Alzheimer's disease. So Dr. Snowden was able to assess nuns while they were alive for multiple years. And then after they passed away, they donated their body and brain to science. And in the study of Alzheimer's disease, that's particularly critical, as many of us know, in that Dr. Snowden could analyze the brain pathology, the neuropathology of these donated brains after these nuns passed away. And one of the major findings was, in fact, for a fairly important subset of nuns, when they passed away, it appeared when looking at their neuropathology that they had Alzheimer's disease. They had accumulation of plaques, tangles, et cetera, neurodegeneration. However, while they were alive, they didn't show any identifiable symptoms of Alzheimer's. So that suggests that we do have an ability, a cognitive reserve, as you will. And how can we maintain that? How can we identify that? So that's one key finding. The second, which is very intriguing too, is that these nuns, when they first entered the convent, they were actually asked to submit essays as to why they were entering the convent when they were around 16 years old, 17 years old. And Dr. Snowden and his team got access to those essays. He did a linguistic analysis of the essays, kind of trying to assess the complexity of language used, et cetera. And what he found was that those nuns that showed greater cognitive complexity in terms of their grammar and writing when they were 16 and 17 years old were less likely to die of dementia after passing away and doing postmortem brain analysis. That does really suggest to us the life course nature of Alzheimer's disease. And I would argue furthermore, if we are going to prevent and reduce risk as it relates to dementia or promoting brain health, it will likely require a public health strategy that focuses on brain health across the life course. I mean, that's a very quick and dirty overview of the nun study, but I mean, that's kind of the way I always like to think about it. Let me turn to you, Dr. Fergan. Again, great presentation. I think someone commented excellent use of visuals, and I would agree they were excellent. I think all the visuals were excellent across the slide. So Josh, what is being done with respect to housing and transportation when it comes to aging? Can you provide examples? And maybe Rajan, you might want to also address this too with your policy insights.
Yeah, so from my perspective, from the research we've done, what we've noticed is there are a few transportation options. There's the Arrowhead Transit service and some other services that exist throughout Minnesota. And you can get those through senior linkage, and you can get access and information that through the aging agencies. However, if you're up in the Duluth area, you've probably seen their ads for drivers. They're really short on staff to make those work. So despite the fact that there are some transportation services theoretically available for folks in Cochiquin County or whatever other county, it's really hard to actually organize that because there's such a demand for those transportation services. You kind of have to have your ducks lined up in a row well ahead of time and know where you need to be and how you're going to get there. And if there's a way we can get and solve this winter issue, we'd really be working, but we're kind of stuck with limited staff and a huge reliance on volunteers.
Yeah, there are transportation and chore are consistently ranked as the top unmet needs in Minnesota's needs analysis. Every county does a gaps analysis, and transportation and chore in all counties across Minnesota, both rural and urban. In the metro area where we do sort of have a lot more services, our transit systems are meant for commuters, not for getting people around their communities for socializing and appointments and those types of things. There are two interesting things that I would point out. One is the Minnesota State Council on Disability is currently attempting to replicate a legislation that we have on the books that allow in rural communities, in farming families, to issue a special provisional license for youth who are 14 or 15 to be able to drive as a way to ensure that, you know, their farm remains vital and active. They're attempting to replicate that across the state of Minnesota so that youth who are 14 can transport a person with a disability or an older person who can no longer drive to medical appointments and other appointments. So that will be interesting to see that coming through and see how much that helps and how much it doesn't help. Another one in the suburbs of the metro area, there really is a lack of transportation. If you don't have a car, you really can't get anywhere. There's a nonprofit in Dakota County called DARTS that has been establishing these partnerships with municipalities called loops. And these loop buses are designed to be active, small buses that continue to go around the community all day, stopping at senior housing, stopping at community centers, the dollar store, that's a big requested one, grocery stores. And so it's a way to sort of solve this issue of our commuter transit system that we have in place. So those are two things I would maybe say about transportation. They're kind of interesting and popping up more.
Yeah, thank you so much, Dr. Moon. You know, we have a lot of questions to get through here, and we're going to just keep moving through them. Dr. Namdul, I will ask you this, and I think this is a topic I think that many of us can weigh in on. So Sana asks, dying well in the U.S. to most is wanting to die at home and not in a hospital, but clearly there are barriers to dying at home and what home means. Can someone speak to what dying well in the U.S. looks like or what it should look like?
Thank you. And I think this is a great question because there's literature out there, books been written over last decade or so, where there have been a huge project that has been done across the U.S. or in North America, looking at the people's preference either to die at home or at a hospital, and majority of them actually have responded by saying they want to die at home, which in fact doesn't happen. And based on my work, trying to translate what I found in India and to bring into the US or North America is really about what kind of a communication is happening between caregivers, particularly attending physicians and patients and their family members. And I think they always seem to be one of the recent manuscripts that I've been working on and submitted. Is really about getting into the nuances of what kind of additional language or the linguistic tool that we need to provide for our caregivers and also for the family members. And I think the work in anthropology or sociology is really kind of coming in strongly because there's a certain level of deficiency, if you will, when it comes to how you can actually, and one of the questions that I saw is really about how you can actually communicate with someone about aging and dying before it actually comes on your face, right? And I think those are some of the things that I think there's a huge lack of, or the poverty of language when it comes to communicating and what kind of options that the patients or the family members can have, and those can be provided by caregivers, particularly in the hospital setting. And I think that's what's lacking, which compared in the field side in India, those are engaged communication happening all the time. I think something that we can look at.
Very good. Rajan, Josh, did either of you want to weigh in on that?
I think, approaching things from a model like we use in hospice, a more holistic, person-centered, what matters to the individual. And there's also an interesting phenomenon of the increase in death doulas. So very often we'll have a doula at an early part of life, helping through, birth, pregnancy, all of that kind of stuff. And there's this new concept of helping people have this death that's their preferred death, that's their preferred way, and having that coach and help. So I'm all for the hospice model. My mom went through hospice, and we really couldn't have survived as a family without it, because it does provide a very supportive path through the dying process.
I think you can make a really strong argument when you think not just of hospice care, but more broadly palliative care. I think a lot of people think palliative care means end of life, but it's really care for chronic or multiple complex conditions over time. You can make a real strong case, look no further than the hospice model, to suggest how we should be caring for people with chronic conditions for longer periods of time. It shouldn't necessarily just be constrained to the certain period of time prior with terminal illness. How we can get to that and how we can achieve that, of course, is another question. Easier said than done, but nonetheless, the models exist. The models are out there that exist, we know are helpful to help us age healthy. It's a matter of scaling them, distributing them, and getting buy-in from the necessary stakeholders to make them a reality. And that includes end of life, but you could go well before that as well, I would argue. So I think we're done. I was going to end with the last question, which we cannot answer in 30 seconds, which, what do you see as the future of aging here in Minnesota? But hopefully you got those insights from these excellent panelists here this evening. So thank you for attending our first session. I really hope you can make the next two sessions, both on Wednesdays, again, starting at 5 Central Standard Time on Wednesdays, where again, we're going to be addressing different topics as they relate to healthy aging. But I think you would all agree with me that this is a tremendous way to kick off our mini medical school session this spring on healthy aging. Again, next week, we're going to be focusing on creating pathways to healthy aging. Same time, next Wednesday from 5 to 6 Central Standard Time. Again, we have an amazing group of experts, and again, I humbly say this, from the Center for Healthy Aging and Innovation. So Josh, you should be joining Chai. That's going to discuss the latest research in aging, healthcare, and workforce challenges. So again, key topics, very aligned with many of the questions here today. And again, we will emphasize how we here at the University of Minnesota are leading innovation in aging. So thank you for your time this evening, and we hope to see you next week. Take care, everybody.